All right, everyone, buckle up, because today we are taking a deep dive into, you guessed it, more insights from the OHTS.
It never gets old, right?
Never. And this time, we're zeroing in on visual field progression.
Yeah.
How patients' vision changed over time,
hmm
both before and after they ended up developing glaucoma.
It is a fascinating area, especially since they had such a huge amount of data in that study. Remember, visual fields like every 6 months
I know.
and optic disc photos yearly. It's an absolute goldmine of information.
Seriously. Before we get into the details, though, can you set the stage for everyone? Remind us about the OHTS study design.
Of course. So as you know, the OHTS was this massive prospective clinical trial.
Huge.
Right? It went on for, gosh, well over a decade. And they were specifically enrolling patients who had ocular hypertension, but at the start, they had no signs of glaucoma. Yeah. Clean as a whistle, no suspicious optic discs, no funky visual fields, nothing. And the researchers were basically watching and waiting to see who would, develop glaucoma and how their vision would change over time.
I see, like a real watch-and-wait approach under very controlled conditions.
Exactly.
Now, this paper we're looking at, it focused specifically on the participants who did eventually develop POA.
Right, primary open-angle glaucoma. That's right.
So we're talking about an inception cohort here,
Yeah, that's a good way to put it.
looking at how their visual fields progressed.
And because they had all those frequent tests, the researchers could track those changes with, incredible detail.
I'm excited to hear more. Okay, methodology time. How do they actually measure the visual field progression?
So they used what's called mean deviation slope analysis,
Yep.
which basically looks at the rate of change in those, MD values from the visual field tests.
Right.
And they were smart about it. They calculated both pre-POA and post-POA slopes. So it gave them a much clearer picture of how things were, trending over time.
I have to ask about this. They mentioned needing at least 5 visual fields over 3 years to be in the analysis.
Right.
Why was that?
Well, it's about data quality, really. You needed enough data points to get a reliable slope calculation. And to their credit, they even compared those who were included versus those who were excluded.
Good.
Just to make sure there wasn't some systematic bias going on. They were very thorough.
I appreciate that. Thorough is good. Now, drum roll, please. The results.
Mm-hmm.
What did they find about how fast those visual fields were declining?
Well, the most striking thing was the variability.
Ah.
Some patients, their vision worsened super slowly, and then others, it declined rapidly.
Really?
Yeah, even with those clinicians watching them like hawks in the study.
So is there an average decline or any specific numbers we can look at?
Oh, yeah, for sure. On average, the visual field loss after a POA diagnosis was minima 0.40 diabetes per year.
Okay.
But, and this is important, 41% of eyes declined by at least 9.5 dBs per year.
That's significant.
Oh, and get this, 5.4% of the eyes, they showed a truly alarming decline of -2 dB per year.
Wow, -dB, that's a big drop.
Absolutely.
Before we move on, I'm really curious. Did the study happen to look at any factors that might predict faster visual field loss? Like what makes someone more likely to decline rapidly?
They did, and this is where it gets really interesting.
Okay, tell me more.
So they found that older age at diagnosis,
Mhm.
a larger cup-to-disc ratio, and higher pattern standard deviation at diagnosis, all of those were linked to faster MD slopes.
Okay, that makes sense. Anything else?
This is a big one. Both the average IOP and how much the IOP fluctuated during follow-up.
So both were important.
Both were significantly associated with a faster rate of progression.
Wait, hold on. So it's not just about getting to your target IOP, it's also about how much that pressure is jumping around.
Exactly.
Interesting.
Imagine it like, riding a roller coaster.
Okay.
The higher the peaks and the steeper the drops, the wilder that ride is going to be. And in this case, the faster the visual field is going to decline.
That's a great analogy. So for those patients who have those roller coaster IOPs, we might need to be even more aggressive with their treatment.
You got it. Even if their average pressure looks good.
I see.
This study's telling us that if there's a lot of fluctuation around that target, up and down, it could still be a problem for their vision.
That's huge. I mean, that really changes how I think about managing these patients.
It really does.
You know what? Before we go any further, I just want to remind everybody that we've got a link to the full study in the show notes.
Definitely worth a look.
For sure. Now, let's unpack those risk factors a bit more. You mentioned age at diagnosis, cup-to-disc ratio, and pattern standard deviation.
Yeah, let's break them down.
Perfect.
So for each year older a patient was when they were diagnosed with POA, their visual field tended to worsen by an additional anomal -0.019 dBH per year on average.
Oh, so age really isn't just a number.
Not when it comes to glaucoma, that's for sure.
And what about cup-to-disc ratio?
As you might expect, a larger ratio, which means more damage to that optic nerve, was linked to faster progression.
Makes sense.
Specifically, for every 0.19 increase in the horizontal cup-to-disc ratio, the MD slope got worse by an additional -0.15 dVAS per year.
Okay, and remind me about pattern standard deviation again.
Sure. PSD basically measures how irregular the visual field is.
Right.
A higher PSD means a more irregular visual field, which, can be a sign of glaucomatous damage.
Got it.
And they found that for every 1.34 increase in PSD at diagnosis, the MD slope was worse by -0.13 dBx per year.
So it sounds like the more damage there is at diagnosis, the faster things tend to go downhill.
Yeah, kind of like a snowball effect.
Exactly. And that's where really understanding how to control that IOP becomes even more important.
For sure. It's not just about hitting a target number. It's about, like we said, minimizing those ups and downs to slow that snowball down.
This is all so fascinating, and I know our listeners are loving it. But why don't we take a quick break, grab a coffee, and we'll come right back to dive deeper into these crucial findings.
Sounds good. And hey, while you're waiting, if you're enjoying this deep dive, don't forget to follow the podcast and leave us a 5-star rating. We really appreciate it.
All right, we'll be right back.
Welcome back, everyone. Now, before the break, we were talking about how thorough the OHTS researchers were with their analysis.
Yeah, they really dug deep.
They didn't just lump all the glaucoma patients together, they
Right.
actually split them up.
Oh, interesting. How so?
They looked at those who developed optic disc POA but without visual field changes.
Okay.
And then they had the group who developed POA that was first noticed because of visual field changes.
Oh, I see.
So some had structural changes first and others had functional changes first.
Makes sense. Did that actually make a difference in how fast their vision worsened?
Oh, it absolutely did. Big time.
Really?
Those who had optic disc POA without those visual field problems, they progressed way slower. Their average MD slope was just -0.19 dBs per year.
That's still going downhill though, right?
It is, and it really highlights why we can't let our guard down even if the visual field looks okay.
Gotcha. So if we see those suspicious optic disc changes, even if the visual field is normal, we got to stay on top of it.
Exactly.
What about the visual field POAG group? How do they do?
Well, like we mentioned earlier, their average MD slope was -0.54 dBs per year.
So almost 3 times faster.
Pretty much. And don't forget, that's just the average. Some in this group had those crazy declines we were talking about, over neckish 2 dBs a year.
Yikes. This really drives home the point that ocular hypertension isn't always a walk in the park, huh?
Not at all. We need to be sharp and manage these patients properly because some of them can lose vision quickly.
Agreed. Early detection and proactive management are key, for sure. Now let's get back to that multivariable model they built. I mean, they really went all out, including age, cup-to-disc ratio, PSD, average IOP, and even IOP fluctuation. It's impressive.
It is. They wanted to create a tool that could predict how fast someone's vision would decline, personalized for each patient.
And did work.
It actually did a pretty good job.
Oh, that's great.
They split the participants into 3 groups based on their predicted rate of progression.
Okay.
And the actual rate of decline in each group pretty much matched the predictions.
So we could actually use this model in the clinic to help guide our decisions.
Potentially, yeah. Imagine being able to pinpoint those patients who are likely to progress faster.
Right, and then we can tailor our treatment accordingly.
Exactly.
Of course, even with a study this good, there are always limitations.
Of course. They were very upfront about those.
What were some of the things they pointed out?
One thing was using mean deviation as the only measure of progression.
Yeah, we talked about that.
It doesn't catch those subtle, localized changes that clinically can be really important.
It's like looking at a forest, but only paying attention to the average height of the trees.
Exactly. You might miss some trees that are struggling.
Did they mention any other limitations?
Well, they also pointed out that they didn't have fancy OCT technology back when they started the study,
Oh, right.
so that wasn't included in their analysis.
I wonder how the results might have looked different with OCT data.
It would be interesting to see, wouldn't it?
Absolutely. It's crazy how much our diagnostic tools have changed since then.
I know, right?
But even with those limitations, the findings from this study are still really valuable.
For sure. It adds to our knowledge about how visual fields change over time in patients with ocular hypertension who go on to develop glaucoma.
It's crucial information for us.
And remember, all those folks in OHTS started with ocular hypertension, right?
Yeah.
So these findings, we can't just assume they apply directly to patients who already have glaucoma when they start a study.
Good point. It's a different population.
And we have to remember, this was a clinical trial, so everyone was getting regular checkups and treatment according to a strict protocol.
Right, very controlled.
In the real world, well, patients aren't always so good about following their treatment plans.
Definitely not.
So we might see things play out a little differently in everyday practice.
Context is key.
Absolutely. But even with all that said, the takeaways are clear.
Okay, let's hear them.
We've got to be vigilant, especially for those patients with higher risk factors.
Right. Can't be complacent just because someone's IOP looks good at a single visit.
Nope. We have to look at the trends over time, consider those IOP fluctuations, and be proactive.
It's about preserving vision, not just kicking the can down the road.
Well said.
This has been such a fascinating discussion. Is there anything else you want to add before we wrap up?
I think the biggest takeaway for me is that we're all students, always learning. Studies like this, even years later, they're still shaping how we understand and treat glaucoma.
It's a great reminder to stay curious, to keep learning.
Absolutely. And to use that knowledge to provide the best care for our patients.
And we are back for the final stretch of our OHTS visual field progression deep dive.
It's been a good one.
It has. Before we sign off, though, I think we should hit on a few more important points.
Oh, definitely.
I was really impressed with how honest the researchers were about the study limitations.
Yeah, me too. They didn't try to sugarcoat anything.
Exactly. Like, they were upfront about mean deviation maybe not being the perfect way to measure progression.
It's true. It misses those subtle, localized changes that we know can matter a lot.
Right. Using only MD to judge visual field progression is kind of like judging a book by its cover.
Exactly. You miss all the good stuff inside.
I love that analogy.
Yeah.
And they were also clear that they were using standard 24-2 and 32 visual fields, so they might have missed some central vision issues that a 10-2 would have caught.
Yeah, that's a good point.
And of course, like we said before, no fancy OCTs back then.
Ah, technology. Always changing.
Can you imagine what the results would look like with OCT data?
It would be fascinating. But even with those limitations, this study is still so valuable. It adds to our knowledge base, especially about how visual fields change over time in ocular hypertension patients who develop glaucoma.
Exactly, and that's knowledge we need to have. Oh, it's worth noting that everyone in OHTS started with ocular hypertension.
Yeah.
So we can't necessarily apply these findings to folks who already have glaucoma when they enroll in a study.
Right. Apples and oranges.
And plus, this was a clinical trial, very controlled.
Everyone's getting checked regularly, getting their treatment exactly as planned.
Right, in the real world.
Let's just say it's not always so straightforward.
Patient adherence, am I right? So the progression patterns might look different out in the wild.
Totally. It's all about understanding the context, you know?
Absolutely. But even with all that said, I feel like there's some crystal clear takeaways here.
Yeah, what's the big picture?
We got to be on our toes, especially with those high-risk patients.
Absolutely. Can't just assume everything's fine because their IOP looks good one day.
Nope. Got to look at the long game, see how that IOP is behaving, are there big swings, and then be proactive.
It's about protecting their vision, not just delaying the inevitable.
Couldn't have said it better myself. Wow, this has been such an insightful deep dive. Thank you so much for joining me.
The pleasure was all mine. And for everyone listening, thanks for tuning in to The Deep Dive. We hope you found this episode helpful and, dare I say, enjoyable. If you did, don't forget to follow the podcast and leave us a 5-star rating. It really helps other eye care professionals like you find us. And if you're really craving more info, the link to the full study is in the show notes. Until next time, keep those eyes healthy and those minds curious.